Hello. I will just give me a second to get my screen sharing up. I'll do that. Oh, screen. Oh. You should be able to see that now. You can see the PowerPoint?
Yes, can see it.
Yeah.
Excellent, excellent. How are you going, getting through this first week?
So far, so good, actually. I'm impressed. I didn't think I would be finding it, understanding it, I should say.
Yeah. Yeah, we'll slowly get through there, and as I said, we revisit points at different points in the term as well. So we're doing pelvis and a bit of the bones and things this week, and the vessels we'll do today, and then we will revisit that again when we do the lower limb, and we revisit again at the res school in week 9. And so it helps you to consolidate and not just learn something in week 1 and forget about it, because we sort of add on, and it's not sort of learn, data dump, do a little quiz on it and forget about it, because that's not the way anatomy happens. Everything's interrelated. So hopefully you'll find that you'll build as we keep going through the weeks.
One thing I do have to ask, going through those photo images, recognition photos.
Yep.
Should we say left and right for everything, if it's on the left or the right side in those as well, just to differentiate?
If it's a bilateral structure, meaning there's a structure like that on both sides, and you can see it on that image, yes, because that image is showing 2 structures, and you need to refer to a right or a left-sided structure. If you get a zoomed up image and it's just of one hip, and I think I'll show you some of those maybe today, you're only imaging that one side. So there's not another sided structure shown on that image, and that's when you don't need to refer to the right and the left sides. Does that make sense?
It does. So on the hip that we see on the lateral view, we don't have to say that it's a right hip.
No,
and
you wouldn't know on those sagittal
down.
views. No, you wouldn't know which one it is either. No, on those sagittal ones. So unless you're told what side of the body it's through, but no, those ones where you can't tell, you're not expected to have ESP. So okay. Those ones,
awesome.
No.
I just assumed it was the right side because of the positioning of the pubis and the ischium.
Yeah, I'm not even quite sure which image you're talking about, but yeah, with some of those ones where it's a parasagittal, if you're not told, you can't tell. So don't even try to extrapolate. Yeah.
Cool. Thank you.
No worries. Okay, so it's 12 o'clock, so we'll get started. This is what we're going to cover in this study group this week. So we're going to look more briefly really at the muscles of the pelvic floor, and you probably saw those videos and just went, oh, what is this area? So we will unpack that, relate it to some images and make you feel quite comfortable with those, and really where they sit relative to one another is what I want you to move your thinking into. And then we're going to look at some pelvic arteries and veins and some nerves. And we already discussed maybe the sciatic nerve and a little bit of the obturator nerve on Tuesday. So we'll move on to just discussing them a little bit more. So as I said, on the tutorial, we covered the bony anatomy and looked a bit at the muscles, the ligaments and fascia. We didn't probably really talk about fascia. We'll start talking about these, some of the pelvic floor muscles and then neurovascular structures. So I've mentioned that word fascia, and you're like, oh, there's too many terms. Basically, if you think of every muscle in the body, it's going to have an outer coating, and it has a fascia that sits around it. So fascia are sort of sheet-like structures. They're big and broad. They're very thin. It's like cling wrap, really, but it's very tough and it's very strong. And it will encase muscles, so we'll have muscle fascia, but it can also enclose and separate muscles and organs. Well, I've said muscles, but also organs and sort of nearly cavities in a way. So in the lectures, I would have mentioned the obturator fascia, and sometimes we'll call it a membrane as well. And so you would have that would outline the outside of the muscle and just define the difference between the internal part of the pelvis and the external part of the pelvis as well. So we're going to talk about the muscles of the pelvic floor. And you hear people talk about them all the time. And, you know, if you're a woman, my light's going out, your pelvic floor is important. It helps to keep all of our organs up in our pelvis, which is fairly important. If there's something wrong with that pelvic floor, the organs can sort of collapse down and go head down more towards your feet direction, which is not good if it's your uterus or your bowel or your urinary bladder. And it can happen to males and females. So it's quite an important structure just to help, you know, if our bowel or our bladder falls down lower and falls between gaps in this pelvic floor, then it can interrupt the function of those organs as well. So it's really like a basin. So, you know, our pelvis has like a little bowl shape, and this sort of lowers down and forms the floor or the lower part of the bowl of the pelvis and holds everything in. We've got different structures, and really on the imaging that we're looking at in this unit, we won't really see the perineal membrane or the deep perineal pouch. So you won't be identifying that on the medical images at this stage. You do need to know that they're present, but a membrane is going to be, you know, how thick is cling wrap really? Like, you know, it's 0.2 to 5 of a millimetre, and we don't have the resolution on the CT and the MR images to really appreciate that. We can see it sonographically, but the sonographic images are too weird for you to interpret. This is what we call a transperineal ultrasound, and it's where it demonstrates the urethra, the vagina and the rectum, and sees if there's any what we call prolapse or the organs coming closer to the skin. So the probe's on the skin of your nether region, and we're looking for organs that prolapse and come close to the skin down this way. And so it's a bit abstract for you to look at, and I'm not at all expecting you to be interpreting these sort of images. This is how it's delivered. This is like a baby's head as it's coming through these sort of levator ani muscles. So you can see they have to get really, really, really stretched out of the way to let a baby's head through in a vaginal delivery. And in that process, they can tear and they can have all sorts of injuries, and depending on how they're stitched back or how they recover can impact whether or not the mother could have some issues with the pelvic floor, and then some potential prolapse or movement of the organs coming through the floor of the pelvis. Is everything making sense so far?
Yeah, thank you.
Any questions or comments? That's a bit graphic. I'll move off that slide so we're not looking at that one. Anyone that's had a baby, we're like, oh, yep.
With the stitching after that, I read an article, and I know it's not a scientific terminology, and I know it's not widely acknowledged, but something called the husband stitch.
Oh, I'm not quite sure about the stitching. I haven't performed any of them myself, so I don't want to tell you the wrong information.
No, it was, from what I was reading, it was just sometimes they will do an additional stitch to make it tighter, which can then lead to other issues because it's been unnaturally tightened.
Yeah, so whenever you stitch something back, I mean, whenever you do an injury to muscle, well, muscles repair fairly well. It would be more the connection of muscles and at the fascia level. Whenever
Okay.
you tear something, whatever surgery you do never makes it as to the original state that it was. There will always be, it won't be as stretchy because you have to develop scar tissue, and scar tissue is a little bit more fibrous and hard. And so depending on, everyone can scar a little bit differently. So depending on how you scar could depend on how tight things could get post some repair in there. So we probably won't cover what happens to tissue once it's torn and what happens to tissue once it repairs in this unit. You'll tend to cover that possibly in your medical pathophysiology unit, where they talk about that. We just don't have the scope to cover it all here. But yeah, when particularly connective tissue, so your ligaments, your tendons and your fascia, have different types of collagen in them. And then when that has an injury, then you get what we call granulation tissue. And that the name of it means it's like granules, and it's more sandy and fibrous than the stretchy tissue it replaces. So post-surgery, nothing's going to be as elastic as it was before the injury and before the surgery. Does that sort of make sense?
Yes, that makes complete sense.
So I find people find these muscles of the pelvic diaphragm, of the pelvic floor. So the pelvic diaphragm is the muscly part, not the membrane and not the pouch part. So the muscles of the pelvic diaphragm, we've got sort of two groups, Nellie. So we've got one called the coccygeus, and we'll go through that, and then another called the levator ani group. And the reason we call it a group is these muscles sort of blend into one another, and you'll see on the imaging, it's really a bit hard to tell which one is which and separate them from one another, because they are so thin and they do blend with each other. And as we look through the images, you'll see what I mean. So this is obviously a female, and it's a mid-sagittal section. So we can see our pubic bone here at the front, and our sacrum and our coccyx, which we can see out here at the back. And then we can, this is the urinary bladder, which is this. This patient, this is what we call an anteverted uterus, and this is what we call a retroverted and retroflexed sort of uterus. It's pointing, the tip of it's pointing back to the spine, whereas the tip of it's pointing more to the belly button and the front of the abdominal wall here. Both are completely normal. Uteruses can just sit in different positions. And then right in front of the sacrum and the coccyx, we have this area of no signal here, which is the rectum.
Does the retro uterus affect the rectum at all?
No.
No, so it won't stop anything or block anything that's coming through?
Sometimes it can change in the same person depending on the amount of bladder filling they had. So this bladder can sometimes get quite full and it will expand, and it can affect the position of this. And when this empties, this might flip back over into this position in the same person. So they're quite variable. Generally, a retroverted uterus, where this fundus or this pointy bit points to the spine, most people will stay like that. Occasionally, it can move.
Okay, thank you.
No worries. So the pelvic floor needs to run from about the side, not the front of it, but the side of the coccyx region to this sort of inferior portion of the pubic bone. And I just drew a line on here. It's probably more this, but you can sort of see, I probably could have drawn that line a bit better. You can see that it's going to help keep these structures up in the pelvis and not let them go down towards the floor. And of course, we need little holes to, you know, let things in and out, well, mostly one directional, but anyway, keep things maintained up in this area for most of the time. On the MR, can you sort of see a little line coming through here and coming down? Can everyone see that?
Yes.
So
Yes.
that's going to be the area of the pelvic floor. So if we look above it, we go, oh, there's organs and things like that. And then we look below it and there's just fat from the skin of the buttocks, really, which is what this bright area is. Can everyone see that? And see how the pelvic floor is maintaining everything up here.
Yeah. Yeah, thank you.
So, our coccygeus muscle is quite small and atrophied. We sort of say the word because we don't have a tail that we need to wag, unlike dogs. So I'm not a vet and I don't know how big their coccygeus muscle is, but apparently it's supposed to be more activated than ours. So I drew in some positions of muscles the other day, and this one's going to really go from the sacrum and the coccyx and across to that ischial spine across here. So this was what muscle was this one here? Which is this one?
Piriformis.
And which muscle was this one down here that sat over this foramen
The
here?
obturator
Obturator.
internus.
Obturator internus. So that's our piriformis muscle and tendon. Now obturator internus muscle, and then it's tendon, both attaching onto this greater trochanter. And then what was this structure here that sort of sat in between them?
Sacrospinous ligament.
The sacrospinous ligament. So we're looking from a posterior approach. See how we're sort of posterior-lateral approach, and we can see this. Immediately anterior to that, can you see there's a little bit of muscle where my arrow is pointing? That's meaning that something's sitting in front of that. That's the coccygeus muscle. So it sits at the same level as this sacrospinous ligament. So this is the ischial spine. It's attaching from the sacrum to the ischial spine. And as I said, this coccygeus muscle attached from the sacrum and the coccyx. It probably runs a little bit lower, and then it runs over, attaches to the ischial spine. But where do we say it sits relative to the sacrospinous ligament, the coccygeus muscle?
Superiorly.
And I was going to say anterior.
Anterior. See how it's at the same superior and inferior level as the sacrospinous ligament. So it's at this same level as the sacrospinous ligament, but it's more to the front of it. So it's anterior to the sacrospinous ligament. Can you see that?
Yep. Okay.
And then where would you describe that the piriformis muscle sits relative to your coccygeus muscle?
Superiorly, or yes, because it's above.
So remember I did a diagram and I said there's your piriformis muscle, there's your obturator internus muscle, and your sacrospinous ligament will come and sit through in here, sort of in between them, as we can see here. And so that's going to be the level of our coccygeus muscle, sitting in between our piriformis, so inferior to our piriformis, but superior to our obturator internus muscle. And that's important for us to understand when we think we're going to look at a series of CTs or MRs, because we're going to have to think, we're going to see structures first superiorly, we're going to see some more slices, and then we're going to see our coccygeus muscle and our sacrospinous ligament at the same level, and then slightly inferior, or sort of at the same level and inferior to that, we'll see our obturator internus muscle. So you can sort of see the piriformis muscle here. You can see your coccygeus muscle at the front, and now we're looking from the front and back. And then what's that white structure there going to be that my arrow is pointing to?
Sacrospinous ligament.
Yeah, which is sitting posterior to the coccygeus muscle. So it could also be called the ischio-coccygeus muscle because it's going to extend between the ischial spine and the coccyx and the sacrum to a degree. So let's have a look. We can see our iliac bone. What are we seeing in here, sort of between our sacrum and our iliac bone on the right?
Piriformis.
Piriformis muscle. We can still see a bit of our piriformis muscle, and we're coming down. We're hitting our ischial spine at this point, because see how it comes right to a pointy bit here and here. So right at this pointy bit, then we can see our sacrum and our coccyx, and we're going to sort of see a ligament sort of structure in there, and then a muscular structure that's pretty piddly and small, which is going to be our coccygeus muscle just there. Can everyone see that?
Yeah.
And as we go down even further, then we start to see this muscle, which is
Obturator internus.
obturator internus muscle. You can sort of see a little bit of it here and here, so you can sort of see that there's nearly going to be a bit of a crossover, but you're starting to think I'm moving from superior to inferior, and I know where my structures sit relative to one another, and I know where I expect to see them on these images, and what we call anatomical landmarks we're going to use to help us confirm that this is the right structure. So we're calling them anatomical landmarks when we look at our MR and CT images, and when we start scanning and looking at ultrasounds, we call them sonographic landmarks as well. They're anatomical structures that we need to see, and they help us identify that we're looking at a certain structure. Is that making sense, or am I speaking another language?
Can I ask a question, please?
Yeah.
Yeah, during assessment, so do you tell us like which level of the section is it? Like, for example, is it a little bit high up or middle or a little bit down? So how can you, like, for example, be sure whether it is, if it is a little bit high up, we could see like some higher structures in the middle or lower. So can you ask, how do you assess this thing, like, during assessment?
You're going to get medical images and have to identify a series of structures from something, from an image in this unit. Is that what you mean?
Yeah, because now maybe just, or just you put this image yourself, which sections I know some, we identify sometimes, based on some structures we see, but sometimes it could be difficult at which section just, the scan was taken and something like that. So
these you would probably just say is an axial section through the pelvis. So you need to be able to follow these, which is why I've given you the series. So you at this level need to go, this image is through the acetabulum. So I know that this image is lower than this image because my iliac bone sits superior to this level. Does that make sense?
Okay, thank you.
Yeah, there's a bit of thinking about it and understanding, and you develop it over time as we look at more and more images.
So on the exam, we will have a row of images to look at, not just one image?
No, you may just get one image. Because that's you might need to say, oh, it's this image. Oh, I can see ischial spines. I know what level I'm at. Or you may get an image where we looked at the other day where it had the pubis at the front and the ischium down the bottom, and oh, my pubis and my ischium are more down in the lower part of the pelvis, that they sit down here, whereas your iliac crests sit up at this level. Does that make sense?
Yes, it does. Thank you.
And that's
I've kind of been telling a lot of people, but there's a website called MRImaster.com.
Yeah,
that's really, really helpful. It kind of has everything labeled, and you can kind of move superiorly and inferiorly through the body.
I've got some images of that here in this tutorial. It can get a little bit overwhelming because it has a lot of structures labeled, and sometimes some of them may not be completely correct as well. Remember, anything that's on the internet can sometimes have errors that haven't been picked up.
Is it an app or just a website?
It's a website. Yeah, it's for free. I've got the references for it on these pages.
Michelle, sorry, can I just ask, when we're identifying them as well, you said on Tuesday, and I just want to clarify, we have to identify the correct sides as well. Is that right?
Yes.
Yes. Yeah. Perfect.
So you remember your first assessments are quizzes, and it will have the answers there. You're not typing them out from in week 4 and week 6.
Okay, thank you.
Yeah. So I've structured the assessment so you're guided through that. You get some feedback, and then you don't start writing answers until week 9.
Okay, thank you.
That's really good to know.
Yeah, and I've done that on purpose so that you Yeah, and there are assessments so that you go through and then you'll get your feedback. So you'll get video feedback from me on the assessments, and you'll also get to see what you wrote or what you picked as your answers, and what was correct as well. And then I go through and say, this was correct because this option was incorrect because.
Okay, thank you. Yes, I just noticed in some of the worksheets I'd completed, I put, you know, for example, obturator internus, but I didn't specify right obturator internus muscle.
Yes. And it's a big thing that catches people out when they do the typing test. So that's why I was saying to you on Tuesday, start to get used to, even if you don't write it, like write M for muscle and just R and L for right and left. So you don't have to write the whole thing, because that's what we do in medicine. You know, like we have lots of little, and you'll see that sometimes I'll just use M for muscle here or R and L for right and left. In the test, you'll need to write out the whole thing. But when you're writing and practicing, just start using some abbreviations.
Excellent, thank you.
No worries. Any other questions? They're all good.
I do have one. With the
Yeah.
wording like ileococcygeus, is
Mhm.
there any particular way it's written? Because I did one that was coccygeus ileo, and I meant it backwards. And I'm like, oh, so is there a specific way which comes first?
Usually it's the proximal attachment to the distal attachment. So anything closer to the trunk is proximal, and then further away from the trunk is distal. Ileococcygeus, they're probably both at the same level, so it's sort of a guess for you. If you do that wrong and incorrect in the test, I can sort of guess what you mean, and as long as you've got sort of the right name there, it's okay, because you're still learning to use this terminology.
Okay, thank you.
You'll find that once we get to the upper and lower limbs, some of the names of the structures are really long, and as long as people have the correct components generally in there, I can see the way you're thinking. And it's all about getting to develop your understanding in this unit. So ileococcygeus, this was our coccygeus muscle here. So where does it sort of sit, do you think? And I've drawn it in. That's the coccygeus, and I've drawn in on the x-ray just so you see where things sit relative to one another, because sometimes this is easier. Remember, this is superior and this is inferior, lateral and medial. How would you describe where it's sitting relative to your coccygeus muscle? The ileococcygeus.
Inferior?
Yeah, because that's a little bit more superior towards the head. It's more towards the head, and this is more inferior. Excellent.
Would it be anterior in the body as well?
Well, this one sort of, see how they run to the sort of the same anterior plane?
Oh, so that's on a little bit of an angle, that
Yeah,
picture,
that's
isn't
on an
it?
angle, yeah. We're sort of looking from the left over to the right, maybe on this one, yeah. And then there's the pubococcygeus. So as the name suggests, it just runs from the pubic bone to the coccyx and the sacrum area. So this is our pubic bone anteriorly here, and it's going to run from pubis to coccyx in more this vertical orientation. So this blue thing's all of the three levator ani muscles together. And then there's a puborectalis. So it runs from the pubic bone and it does a sling all the way around. If it's got rectalis in the name, it means that it's the sling around this hole. And what's this hole for here?
The anus?
Anus.
Yeah. So it's the anorectal junction. And so it's going to be where the poo goes through. That's sort of your poo hole there. So it's a puborectalis, and see how it's a sling around that poo hole. Like, I know that's not an anatomical term, but I'm just trying to make it easy for you to understand it. And so we say it maintains fecal, that's another word for poo, continence. So continence means that it's incontinent, means that you can't hold your bladder or can't hold your bowel.
You leak everywhere.
Yeah, it's a leak. And so this is stopping poo leaking is what that sentence means. So you can see that they sort of form this whole basin, and as I showed you before, maintain everything up in the pelvis. And so I sort of drew in here your piriformis muscle, your obturator internus muscle, your coccygeus muscle, and your levator ani muscles. So these together form the pelvic diaphragm. These together form the lateral pelvic walls. Everyone's following so far?
Yep, all good.
So we sort of looked at this on a sagittal section. We can sort of see where they sort of sit on an X-ray. So let's look at a coronal MR. So this is one that's taken through this plane. So these images, when you're looking in your text, this shows where the slice is acquired through. So you can see it's more at the back. That's from a sagittal slice, so that's where the coronal slice is taken, and then it showed you where the coronal slice is taken or acquired from in the axial or transverse plane. Can everyone understand what these images here are showing? They're showing where this slice is sitting.
Yeah.
So when someone asked about how do you get used to where the position of the slice is, when you use your textbook, it will show you approximately what level those slices are acquired in. And sometimes I snip it out just so that I can fit more images on these, but they are in the text on a lot of your images. So this is a more posteriorly located, because this is posterior and this is anterior, located coronal image. You can see there's an S for superior, an I for inferior, and an R for right, and an L for left. We can see sort of the sacrum here. And then we can see our piriformis muscle. Can you see the piriformis muscle is on a bit of an angle? Like it's not, it doesn't run in a complete horizontal plane. It runs like a little bit of an A. Can everyone see that?
Yep.
Yeah. And then this sort of area here and here is the region of your levator ani muscles. So see, they sort of come and it's not a straight line either. It's like a basin, but it helps to hold and maintain structures up like that. So you can sort of see that it's like a basin as well. Can everyone see that?
Yes.
And there's a series of them. So we'll have our more upper level coccygeus will be above this, and then we'll have our iliococcygeus and our pubococcygeus and ischio-coccygeus more inferiorly down here. We can sort of see this is the ischium bones, which we expect to see because we know our ischium are more posteriorly located bones. This is an axial view, and so this is a zoomed up view, and I find sometimes students get a little bit, oh, there's no landmarks there. So I've sort of shown you some other views here of what level we're approximately at. So it's probably more this level is where this view is at. So you've got a more holistic view here. So we can see our pubic bones, we can see our ischial bones, and we can see our femurs out here. So we can see the pubis, and we know that there's a sling that comes around, comes from the pubic bone and around and comes back to the pubic bone. So what component of the levator ani muscles do you think we might be looking at this level here?
Is that
Puborectalis?
Yeah, because it's a sling, because it's coming from here, it's going down, and it's coming back that way. Can everyone see that? See, it's like this one here. That one.
Oh, yes. Yep. Okay, I can see that now.
Yep. So it's coming from your pubic bone. So we can see the pubic bone in the view, and it's extending down. It's going around the hole, poo hole, and coming back. So this is the urethra. That's the wee hole. And this is a male because it's got a prostate. And they only have sort of 2 holes. Females will have 3 because they will have the vagina in there as well. So this is coming around, and that's the anus there, and it's running around there. You can sort of get an idea of where they sit, and the slices, depending on the images of the slices, you can see different views of them. Can you see it just here?
Mm-hmm.
and in through here as well, different components of those levator ani muscles. Is everyone following? It can be a little bit abstract, but I'm just wanting you to get that idea of the sling, and that those levator ani muscles are helping to hold everything up in the pelvis.
In the lecture 2 slide notes that you've given us, it's page 20 that the levator ani muscles with the
Yeah, did I
show
show the anorectal junction and how it separates the difference between the rectum and the anus?
It's got not on that slide, but it's got the pelvic diaphragm, levator ani,
yeah,
and then all those bits and pieces.
Yeah, it's just knowing that they're very inferiorly located, and basically once we get through those, you're not going to see pelvic structures, you're just going to see muscles then, and you're going to start heading into the thigh region, because it separates the pelvis from your upper and lower limbs. It also separates your pelvis from like the perineal, some perineal structures as well. I think we've covered that. It's like a bowl. So
another question, sorry, especially the MRI images, I think there's T1 or T2 weight images, and so sometimes the bone and the soft tissue appearance could be just variable. And so you mind, like, because sometimes even the appearance of the tissue could help us identify which structure is bone or soft tissue, or sometimes fat and something. And maybe just I missed that, just information. Otherwise, I would be happy if you just elaborate a little bit more on that.
Yeah, it gets a bit hard. The reason we have different weightings is to help us to identify more pathologies and fat content and water content of structures. I don't really have the scope in this unit to go over the different T1 and T2 weightings. I have done a lot of MR in the past, and so I could go on for hours about the MR physics and everything like that, and totally bore you. The muscles will generally, you're looking for pattern recognition of where they sit relative to structures. So when you get an MR, it might say what it is, but it's going to be fairly obvious in ones that we've covered as to what it's demonstrating. So you can have different MRs that are fat saturated or inversion recoveries where the bones are really dark. You won't be getting any of those because they're more focused on finding pathology. So we're probably more going to use T1 or proton density weighted images rather than even T2 weighted images. For everyone that's sitting there going, she's speaking another language, MR is another language. They have lots of different sequences. You can acquire them in all different planes. We're going to mainly stick with your 3 main planes here. So your coronal, your sagittal, and your axial or transverse. On any weighted image, you should be able to identify by pattern recognition what is generally bones. I'm not going to be asking you really abstract things where you can't, and you probably won't even get zoomed up images like this, because I would expect that at this stage, you're still looking holistically at things, which is why I've given you these images in addition to this to help work out where we are. I don't know if I've actually addressed your answer there, but I probably can't. I can't go through everything. Is that okay?
Because sometimes if you are consistent with your slides, I think it will be all right.
Yeah,
but
you won't get anything abstract that's you've not been exposed to.
All right, thank you.
Yeah. Okay. So these ones, they would be T2 weighted, even though I said that we probably weren't going to use those. This is really just because it really highlights the position of the bladder, which is showing as bright, the fluid is showing as bright signal here. I'm trying to think of what I was showing. Now, someone was asking about, are muscles different in size? This person here has got quite a big, chunky piriformis muscle, which is here. And we're wanting to find where our levator ani muscles sit relative to our piriformis. So on this one, you're thinking, I have no idea where it is. Well, let's have a look and follow some of them through. And it's hard to find things, but if you know this is the urinary bladder, you know that your pelvic floor, your levator ani muscles will need to sit below this. because they have to hold it up in the pelvis. And you can see that these are from MRI Master, and you can see how many labels they have on them. And I've got the website down here. I've referenced it. They are good, but sometimes people find that so many labels are a bit overwhelming, and you just think, oh, am I supposed to know all of that? And no, you're not. You're supposed to know the things that we go through here. So yes, it's good, but it also can be a bit confusing in a way. And some of them, they try to figure things out, but some of them, there can be a few little errors that I've seen in them. Basically though, this is, levator ani muscle level. Can you see that this is between pelvis and leg? And even if you can't work out what half these other things is, you can probably go, well, there's no organs down here and there's organs up here. I'm definitely going to be looking in this plane between them, and that's the plane where my levator ani muscles sit. Like, sometimes keep things really, really simple and don't go into too much detail, because you'll start to go a bit crazy, and you have to often go back to rational thought and think of things really rationally. Can you see the thinking I'm trying to get you to develop?
Yeah.
Yeah.
They've labelled some of these. Often on MR, it can be really hard to tell, particularly on these. I wouldn't be asking you if it was the iliococcygeus or the pubococcygeus. That's too hard. You really need to be able to say it's the levator ani muscle group at this stage. I've put some in there just for you to go through so you can see some of them. I've given you some examples. I'll let you go through them and have your time yourself to go through and see the labels. We will cover some of these organs when we do the viscera of the pelvis, and so some of those images will make more sense. Let's just look as we think about our levator ani muscles from a superior to inferior orientation, as we would need to if we were following images in an axial view. So our coccygeus sits more superior. Then we've got our iliococcygeus and our obturator internus. You can sort of see they sit at about the same sort of level. And then we're going to have our puborectalis and our pubococcygeus, which sit at the same level. But we could definitely tell a difference between our coccygeus and these levator ani muscles. So let's have a look through. We're at the pointy bits here. What is this pointy bit of bone called?
Ischial spine.
Yeah, can you see how when you look at these series of images, you can sort of start to see, I can pick out levels. I can pick out my ischial spine level. I can pick out the rounded femoral head and that mid-acetabulum level. And then I can come down and I can pick my pubis and my ischium, and I know that this image is more inferior to this image. You're starting to get that developed?
Yes.
Okay, so we're up at ischial spine. If we went up higher in the pelvis, we would just start to see ilium and the iliac crest areas. We're at the level of our urinary bladder, so we're still in organ territory of the pelvis. We can see our obturator internus muscle here. I can see a bit more of obturator internus muscle, and we can start to see the coccyx and then the rectum anterior to that. And so then we can start to see some muscles coming through from this coccyx layer and running anteriorly here. We probably have a tiny bit of a muscle here. What muscle would I probably be pointing to here? It's very, very piddly, not easy to see. At this ischial spine level. So we're sort of up at this level, aren't we?
Coccygeus.
Coccygeus. Can you see up at this image here? If you point to ischial spine, which is this, you can see we're at coccygeus level, which is this. Can you see how piddly it is? It hardly looks like anything's there. It's on some people you can't even see it. It's so small. And then as we come down, then we're going to come into our iliococcygeus sort of level, and we're in like our levator ani muscles, and we can see the puborectalis sling in here. And so we can see that we've scanned through our levator ani muscles all through these axial slices from sort of superior down to inferior.
Sorry, Michelle, I just can't see the very last photo. Can you point out what we're looking at there?
We're probably right at the very end of it, just that tiny
Okay.
thin bit there. Can you see that?
Yeah,
It's
thank
just
you.
an inferior portion of this here.
Okay, right.
Yeah, it's very thin because it's right at the bottom of it.
Okay, thank you.
Yeah. That's a good question. Any other questions? Are you starting to follow them as we go through these series of images? Sort of.
Yes, thank you.
It's a whole lot of words. They're very long. I think we'll leave it. We're just on the very top of the piriformis muscle here. We can just sort of see how piddly these coccygeus muscles, so it's running between the coccyx and this ischial spine. Can you see that there? It hardly looks like anything. Can everyone see how small it is and why it's forgotten? Not much goes wrong with that coccygeus, but it's a landmark, and it's one that it's a separate muscle to your levator ani muscles.
How come on that middle image the coccyx isn't white, showing up as bone? Is that because it doesn't show as bone on there?
So when you have bone, you have what we call cortical bone. Have you learnt about bone in your other anatomy units? So you have the very outside part of the bone, which is the cortical bone, which is really solid and tough. And it has no water in it. It's just pure compacted bone. And then what's the type of bone that you have in the middle of bone?
Spongy.
The medulla, and it's spongy, which indicates it's a bit softer and it's got bone marrow in it, doesn't it? Have you ever eaten like
lamb? Yummy.
Lamb, and you get the marrow and it's soft, but the outside bit, you suck that out and then you've got the outside bit of the cortical bone. Is that making sense? So the outside bit of the cortical bone that's really hard doesn't have much water in it. And as I said the other day, the MR is all based on imaging water. And so the tendons and the ligaments don't have much water, so they show up as dark. And then the outside bits of bone will show up as dark, but the inside bits will show up as more bright on things because there's more water in there. And so that's why when we look at see this bone here, and it's actually got a dark outside rim and then it's brighter inside. So the outside bit here is where the cortical bone is, and this is more going to be a little bit more spongy. It still can be hard, but you'll have different components of bone.
Okay, thank you.
And so this is the coccyx, and it's so small that it only has the hard cortical bone, and it has because it's so small, there's no room for spongy bone in the middle. That's why it's all dark.
I actually thought that was the rectum to start with, and I'm like, nope, that's a bigger hole.
Yeah, the key is probably looking for this, we call it the gluteal crease or the butt crease. So that means it's right at the back. So then you look immediately anterior to that because your coccyx sits really posteriorly. So people often fracture it if they fall over and land on their bum because it doesn't have much padding around it. And that's there to protect these internal organs. Okay.
Thank you for that.
No worries. I will leave this, and I leave them. I'm just being cognizant of time, and I've just got them in there. So you've got them in a series from superior to inferior, and you have them in your notes to go through in your own time. You do need to just sit there and go through some of these. As I said, we will go over them again when we do the lower limb because we will revisit some of these muscles around. There's a whole lot of other muscles there, and you'll get to know some of those as we do the lower limb. Just trying to ease you into it this week. So we've sort of covered these lateral pelvic wall muscles and then these pelvic floor and pelvic diaphragm muscles here, and they make up everything to hold all of those pelvic organs inside that bony pelvis. And the bony pelvis is in there to protect organs, but also to protect a developing baby when it's developing in the female pelvis. We've done the ligaments. We've talked about where the coccygeus sits relative to the sacrospinous ligament and the relative start to think of where structures sit relative to one another. If you've got Draw It to Know It, it's got like a nice little diagram which can help you unpack it to a degree. If you want to sit there and draw it, it's color coded them for you, and that's sort of unpacked everything that we've talked about there, and where little structures can sit in the spaces of those muscles. I just put it in there so if anyone didn't have time to look it up, that they would have them. Any questions on what we've gone through so far?
And the other thing, the complete anatomy still doesn't work. I think this is an issue for most students, I guess. And I was asking students, but one of the colleagues, she said like she just tried it millions of times, and at the end of the day, it says like registered. But I don't know what's happening to the.
Sometimes it's funny. I think it only works on one of your devices, not multiple. So if you've registered on different devices, it won't work. I think in the information to register, there's an email you can email. It's like 3D 4D Anatomy. Have you got that email address?
I used the information you just posted on Moodle.
Yeah. Did they have if you're having trouble, an email address to email?
No, I haven't seen the email address, sorry.
Oh, okay. I may find it out and I'll get it for you, and I'll post it after this. I usually don't touch my computer while this is rendering after the recording, because sometimes it crashes and then we lose everything.
Okay.
But when this is all finished rendering, I will post the email address. Sometimes that can happen if you've registered on different devices and tried it and it wasn't working.
Maybe just I used it just on my phone before, but now when I tried on my iPad, maybe that could be the reason.
Yeah. So they may need to sometimes cancel one registration or something like that. I'll get the address and just email them. It is an overseas based thing, so it can sometimes take 24 to 48 hours to get a response from them. But they do come back and help you to fix it up. But it will be good to get it fixed up.
All right, thank you.
Okay. Any other questions before we move on to, I've missed the chat. Have I missed anything in the chat? Just answers. Was that more about the complete anatomy? Yeah, I'll post the email address. Sorry, just tell me if I'm missing anything in the chat. Okay, so let's get on to the neurovascular structures, and I'll try and simplify these down. So we talked about the VA and the veins, the arteries and the nerves. Just VAN is an easier word to remember than AVN. So just make a word out of things. So when we get to the anterior part of our, what we call groin, and I'll tell you what the groin is shortly, you need to think of structures moving from a lateral to a medial approach. When we've talked about the muscles, I've talked about them from a superior to an inferior approach. Some of these structures are very important structures. This femoral nerve and the femoral nerve, not as important, but the femoral artery and the femoral vein are quite important structures. We look at them a lot sonographically, and we have to know where they sit relative to one another, and we don't ever want to get the artery and the vein mixed up. So it's really important that we have a way of remembering them, and definitely knowing how we can, without even using other things, know position-wise how we can determine what is the femoral vein and the femoral artery. So we'll go through that. Just to put it into context, we have arteries. A stands for away. Arteries take blood away from the heart. So they're going to take it to the tip of our head, to the tip of our fingers, and to the tips of our toes. Think of that as arteries, all the way away. It comes out through our left ventricular outflow tract into our ascending aorta, then through our arch, down through our descending thoracic aorta. If it's going to our, we're talking about a pelvis, so it's going to come down through our abdominal aorta and then into our pelvis this way. Obviously, if it's going to take blood to our head, it's going to come out through our head and neck vessels off the arch and take blood to the arms and to the brain and the head and things like that. Because we're talking about the pelvis, we're thinking of blood coming out of the left ventricle of the heart, ascending aorta, aortic arch, descending aorta, coming down our abdominal aorta, which when that extends down to our umbilicus or belly button level, and then it bifurcates. So when we talk about arteries branching, we say they bifurcate. And so where it bifurcates is the aortic bifurcation, and it bifurcates into iliac vessels, and in particular, common iliac vessels. So the right common iliac artery and the left common iliac artery. So you can see the acronyms I've got here. That's just saving us type all of those words out. And these iliac arteries are, well, the common sort of comes down and then it bifurcates again into a really sort of piddly internal iliac artery and a really much bigger external iliac artery. So the internal iliac artery is going to take vessels internal to the pelvis. The external iliac artery is going to take the blood external to the pelvis and down to the leg. And that's the way I want you to think of the names of those vessels, because there's so many names, but those vessels are really quite important. And in ultrasound and medicine and radiology, we look at them a lot. So we have to know where they go. Likewise, the veins are going to bring the blood back from the very tips of the fingers, through our arms to our heart, from the very tips of our toes, all the way back up to the body, through the pelvis and back up to the heart, and from our head, drain it back down. So we say veins drain the blood and arteries take the blood and transport the blood to structures. So we start to use that word veins drain. And so I've got an arrow of the veins coming back up from the leg, and then they're going to go in the opposite direction to the arteries. So they're going to come from the femoral veins of the leg and then up through to the common femoral vein, through to the external iliac vein. It's going to meet with the veins draining our internal organs through the internal, because it was internal to the pelvis, and then come up to the common vein because it's common to these two, and then it drains into our IVC, our inferior vena cava. Any questions about the veins and arteries so far? I think the basics of those you should understand. That's been covered in your other units. Is that right?
Yes, thank you.
Yeah. Okay. So we're going to talk about pelvic arteries. So we're going to have our aorta come down to as what we're going to refer to it as our umbilicus. And then you can see at this point, it's going to bifurcate into our right and our left common iliac arteries, which you can see here, right common iliac artery and left common iliac artery. What's this vessel here going to be?
Internal iliac artery.
Yeah, and which one?
Sorry, which one were you pointing at?
This one.
Left.
The left.
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 Yeah, so remember there's two on this image, so we have to call that the left internal iliac artery. And then this one is going to take the blood external to the pelvis and to the legs. So which artery is this?
The
Femoral.
left external
The
iliac
left.
artery.
Excellent, the left external iliac artery. So I've sort of drawn them on here, and it's really easy when we look at this and we forget where it sits on the body. And so we have to sort of think of the two things together. So here's the aorta. I've labelled them for you. Right common iliac artery, left common iliac artery, right internal iliac artery, left internal iliac artery, and we've got the two different branches of those. Then we've got the right external iliac artery and the left external iliac artery. This external iliac artery basically comes to about this level of the groin crease. This is what when I say groin crease, see this crease here between your thigh and your pelvis? That's your groin crease. So at about this point, right at this point here, is an important area that we often look at things. And we have what's called the common femoral artery or vein. It's like very short, and it's not really demarcated by where vessels branch or drain back into. It's just really what the vessel is at this groin crease area, and then it often divides just distal to this. This groin crease is this often you'll see anatomy drawn, and it's indicating what we call the inguinal ligament. And we'll talk about that when we probably do the upper limb, the lower limb as well. The inguinal ligament actually sits up a little bit higher up here. So it's really important that if this is drawn into anatomy diagrams, you don't think this inguinal ligament is this thigh crease, this groin crease, thigh crease, whatever you want to call it. This groin crease sits down here and your inguinal ligament level just sits a little bit higher up there. So this will be our external iliac artery here. What vessel do you think that one might be?
The right internal iliac artery.
Yep, the right, because it's going to go in and supply the internal pelvic organs and structures with oxygen and blood, usually oxygen rich blood, which is why we tend to draw the arteries red and the veins blue. Don't go too much into these vessels. I've highlighted them for you, but it can get a little bit overwhelming. There'll be a few that we will talk about at different sessions, and we will come to those when we need to. But mainly just let's focus on getting the big ones and what the names of them are and why the names are there correct, because it will help you a lot more when you go on to subsequent units and gives you something that's relative to think about. So the veins, as I said, they're going to drain the blood back. So you can sort of see I've drawn the arrows. Why is this arrow going down and this arrow going up?
The veins coming from the head are going back to the heart, and the ones from the body are going back to the heart.
Everything's going back to the heart. So yeah, these ones will drain from the upper limbs down and also from the head and neck down to, and where do our veins drain into? This is our superior vena cava and our inferior vena cava. What chamber of the heart do they drain into?
The right side.
Yes. Which right-sided chamber in particular?
I want to say ventricle, but I feel like that's wrong.
Right
the
atrium?
Right atrium. Right atrium.
That's right.
So, but good for having a go. Because there's a 50-50 chance. So the blood returns to the atrium first. So the SVC and the IVC will return to the right atrium, because they're taking deoxygenated blood, and the right side of the heart will take the blood to the lungs to be reoxygenated again. So the blue is indicating the IVC and the red is indicating the aorta. So the blue has blood traveling that way and the red has blood traveling this way. How would you describe the relationships of the IVC and the aorta at this point in time?
The IVC is lateral to the aorta.
They both sort of sit like they're, yeah, it sort of does, but that's probably not going to help when you're scanning and you can't tell what's lateral or what's midline if the patient's all in their fetal position, which often they are. So let's try for a better description than that, even though that is actually probably theoretically correct.
Would you say that
Will it be
the
posterior?
IVCs?
Sorry.
No, you're right. You go.
Will it be posterior?
No. What side of the patient is this?
Right.
Right.
Side.
And what side of the patient is this?
Left.
Left.
So maybe that's the most obvious relative terms we can use in this picture, isn't it?
Oh, we're all overthinking it.
Yeah, I think you're all overthinking it.
So
Let's
would
keep it
right
nice and
lateral be
simple.
correct? Right lateral, would that be more?
The IVC sits to the right of the aorta, and the aorta sits to the left of the IVC. Did you see
So
what I
you-
did
it
there
would
with
be
my
comparable.
description? Things are in a relative description to something else. So when you're saying it's lateral, you really need to say it's lateral to something else. And it needs to be lateral, usually not from midline. So you might have something here and something way out here. That would be probably more lateral. See how they're so close together? Lateral's probably, it can, because it's right near the midline, and both of them could potentially sit lateral to the midline, it can get a little bit confusing. That will make more sense when we do the abdomen and I start showing you where the aorta and the IVC sit in CT and MR images. And
So at
ultrasound
this
images.
stage, it'd be just right.
So the IVC sits to the right side of the aorta and the aorta sits to the left side of the IVC. Did that sentence make sense?
Yeah.
Yeah.
So we don't have to specifically say where in the body it is at that given time?
No. Just if we were saying, like, looking at this and these, we're talking about where these structures sit relative to one another.
Could I get you to say it again, please?
So the IVC sits to the right side of the aorta and the aorta sits to the left side of the IVC.
So is it when we're discussing obviously an MRI or a picture, we're discussing what is directly in front of us, not how it would normally sit anatomically on a person?
So I'll show you here. So this is your aorta. I'll see if I've got a CT. Okay, here's a CT. This is our spine. This is exactly midline.
Hang on.
Both of them sit lateral
that's
to
better.
midline. Can you see what I mean? The aorta sits slightly to the left side. It sort of sits midline, but just slightly to the left of midline. And the IVC sits slightly lateral and to the right of midline. And can you see how they're both near the midline? And lateral can be very confusing and not going to help you to discriminate which is which. But on this, the IVC definitely sits more to the right side of the patient, and the aorta definitely sits more to the left side relative to one another. Is that making more sense?
I'm not sure if I've got the right screen in front of me. Is it, you've got a CT contrast enhanced studies slide? Yep. Can you show us again? Sorry then.
So this here is your aorta.
Ah, I see. Okay.
And this is your IVC.
Perfect. Okay, thank you.
And I've got this in here because we were talking about MRs before. This is what we call a non-contrast CT scan. And contrast is when we get iodinated contrast media or dye. We often call it dye to the patients. We will inject it into a vein in their arm and then it distributes through their body. We can usually do what's called an arterial phase or a venous phase of imaging. And so these are your kidneys. Without contrast, they just look grey, but with the contrast, you can see that they're a bit brighter. Without contrast, the aorta and the IVC and where they're sitting is a bit vague, but you put contrast in and they light up and they're much easier to discriminate. Can you see that?
Yes. Yeah.
This is actually to show, this is the pancreas and there's some change going on in that. But I just wanted to highlight what a non-contrast and a contrast enhanced CT and why you're going to see things of different levels of opacification on the images I use when I'm starting to point out the vessels that you will see. The best thing to do is to know where the structures sit to help you identify what structures we are actually looking at, because sometimes you won't get the exact phase of contrast that you want. Let's go back to this. And So when we look here, you can sort of see the aorta sitting in anterior to these vertebral bodies, but just ever so slightly to the left of midline, and the IVC ever so slightly to the right of midline. Can you see that?
Yeah, thank you.
Yeah, nothing's huge, like everything's close together in the body, and things can twist around as people get older, and they might have a twisted spine, and so something might have sat more lateral on someone, but once their axis of their spine changes, everything changes, but you need to know where the structures sit relative to one another. And the IVC should never sit over on this side to the left side of the aorta, or else something's weird and wrong, or they've got some really unusual variant. The IVC
Question.
also, yeah.
In people where their heart's on the opposite side, is their IVC and then their aorta switch?
So there's different sorts of changes we can have. You can have what's called situs inversus, where everything in your body is switched around. You could have dextrocardia, where just parts of the heart are switched around. So there's variations on what people may have, and it gets very confusing. The situs inversus is really bizarre when you first look at it, and I've seen it a couple of times, and the patients don't come in and first thing they say is, I've got situs inversus. You put the probe on and you're like, am I having like a stroke or something at the moment? Because you're like, why is everything all the wrong way around? And then it's usually after, you know, a few minutes, and you're standing there going like this, and then you're starting to go, have you had you usually say, have you had imaging before? And they're like, oh yeah, that's right, I've got situs inversus. And you're like, okay, may have been helpful to know that before we started this scan.
Wouldn't they put that in the notes from the doctor who's referred?
Oh, you would think so, no. A lot of the time stuff aren't in the notes, and if you're working in private practice, you don't get notes. All you do is get a little referral, which has hardly any information on it, which is why questioning the patient is so important. Even if you're in a hospital, you often don't have, you know, minutes and half an hour to look up notes before you do a scan. You do rely on what information is provided to you on those referrals and what information you get from your patients. So yeah, it can be challenging at times. I think what I wanted you to notice here is the IVC, and I'm saying come down, the blood does come back this way, but it doesn't say, the vessels don't say can stay consistently to the right side of the arteries. Can you see that? The veins end up sitting medial.
Internally, yeah.
Yes, to the arteries at this stage. So just because you've got the relationships of structures sorted up here, things change as we go down more distally or inferiorly. And this relationship, this is the inguinal ligament level, and so the groin crease will be more down here. But this relationship of these three structures, the femoral nerve, the femoral artery, and the femoral vein, is important to appreciate. And you can see that it's inverted from one side to the other. So it's good to have a strategy of thinking at this level, when I'm looking at the groin crease level, I know from lateral to medial, I'm going to see the nerve, the artery, the vein, and even in here we have lymphatics that run from lateral to medial. And so can you see? We've got the nerve, the artery, and the vein. And then medially, you're going to have gonads. So often we say at the level of the groin crease from lateral to medial, we see the N, the A, the V, and then you can just say the Y front. So that's navy, and it will go navy that way. So I've got some navy men there. Or you can have NAVL. The L is for lymphatics, and navel. So we often use these, or I have to use things to make myself remember them, because there's no way we can possibly remember everything. Our brains are only so big. So we're going to think from lateral to medial at the groin crease, we have the either navy or navel sign. I think I had a little picture way back here, and you probably wouldn't have realized it. Oh, no, it's coming up. Well, I can use this one. See the N, the A, the V, and the Y fronts would sit here from lateral to medial. So we've got the navy sign, and it's going to be the opposite direction coming in, N-A-V-Y, on when we look at the left groin. And let me go through and I'll see if I've got some more pictures to show you. We look at this groin crease level a lot. Oh, here it is. The N, the A, the V, nerve, artery, vein. Lymphatics is often drawn green. So I've got L, or you can have N-A-V-Y fronts. Let's have a look. This tiny thing here is the nerve. It's piddly. It's really small. It's really hard to see on image. I've drawn it big, but it's actually really small. That's the femoral nerve. This is a femoral vessel. Which vessel will this be that's sitting immediately medial to the femoral nerve?
The artery.
The artery. And then this one that sits medial to the artery will be the
Vein.
vein. So we've got N-A-V-Y fronts. Can everyone see that? Subsequently, on this side, we will have N-A-V-Y front region. Casey said the arteries tend to look more circular, and that's right. Can you see this is the artery, and the vein actually looks quite big here, doesn't it? But the vein doesn't look round.
I was going to ask about that. The vein seems bigger than the artery. I always thought it was the other way around.
No, the veins can change in caliber depending on your degree of inspiration, your breath in or your breath out. If you're really taking a big breath in, which often patients are when they're having a CT scan, because they take one breath and then the CT does this run and it does all of the images in one breath hold. So they're taking a really big breath. And so that's why in these CT images, the vein looks much bigger because the patient is taking a big breath. This is an ultrasound. And so this is why I'm saying this is really abstract. An ultrasound is really abstract for you to look at because you don't get all of this relative anatomy. You can't tell from this image unless we label what's lateral and medial. So this is what your femoral nerve looks like. It's like a very disappointing croissant. If you went to the bakery and your croissant was that thin, I would be disappointed. But can you see it's like really piddly and a flat looking thing? It's not a round looking thing. And then a big rounded femoral artery. And then the vein is once again not completely rounded. So when we do an ultrasound and we look for a DVT, a deep vein thrombosis, we look at a vein and then we press the probe in and we squish the vein because veins are really squishy because they don't have those 3 layers of walls like an artery does. You know how your artery has your intima and your adventitia layers that make it more elastic because it has to pump the blood away from the heart. It's more pumpy, I suppose. And the veins are just draining blood back up to the heart. So this is the same sort of transverse view, but it's only just looking just at this little area here. And that's usually what we see with ultrasound. We look with a probe that's only got a footprint that's about 3 or 4 centimeters wide. So this is the whole ultrasound image. I haven't cut any off. That's just what we see. And so when you're learning anatomy, it's like can't tell what's what unless we nearly have to give you the answer. So that's why we're starting with these.
So Michelle, if you squish it, like you just said, when you're looking for a deep vein thrombosis, what does the vein do, or what doesn't it? What is it meant to do?
So the two
not
walls,
the arteries, sorry.
Yeah,
the vein should close up.
The 2 walls should come and oppose one another, and we don't squish it for long. It's like that much, like push down, pull back. The reason we do that is if there is a thrombus in there that we are looking to exclude, the thrombus can be completely anechoic or hypoechoic, so it can look completely black, So it doesn't look like when you do your B mode image that there's anything in there, and it would look like there's just blood. But when we go to squish it, it doesn't squish, and you go, oh, hello. It looked like that was going to be blood in there, but it's not squishing, and that is acute or very new thrombus. And the reason we're worried about thrombus is because I showed you that the veins take the blood back up to the heart, and a thrombus can break off from here and then go up into the right atrium of the heart, and then the right atrium of the heart sends blood to the lungs here, where the vessels get very, very small, and then that little bit of broken off thrombus blocks a blood vessel in the lungs. Then that bit of lung is not getting oxygen, meaning it can't move, and depending on where that blockage happens, when your whole lung is not moving and you're not breathing, breathing is fairly vital to life. And it doesn't have a good outcome if it's not managed early. And that's why the DVT scans are so important, and that squishing is important.
Okay, excellent. Thank you.
No worries. Okay. I've given you some MRs from this MRI master that we can go down. Let's look. Here's a rounded vessel sitting anterior to the vertebrae. Looks like it's more in the midline. And when someone said the IVC sits lateral to the aorta, I said, yes, you are correct, but not in all cases. So this is the aorta, it's round. This is the IVC, and it's not completely round. It looks more like an eye shaped, and it's squishy sort of looking. Can everyone see that here?
Yeah.
Yeah.
The IVC is definitely sitting to the right side of the patient, and it's definitely sitting to the right side of the aorta in this patient. Then we go down a little bit lower, and we're starting to see vessels, and it gets a little bit confusing, but we're knowing that the aorta and the IVC, there's been bifurcation. So we're at common iliac vessel level. So we've got common iliac vessels here and common iliac vessels here, the right common iliac vessels and the left common iliac vessels. The artery is probably more rounded, and the vein is more squishy. The vein is starting to sit a little bit more medial as well, but it's a little bit posterior there because it had to go behind to bifurcate. As we come down, we can see the external iliac artery here. Hang on, why have we got external iliac? Oh, so it's bifurcated. The common iliac artery has bifurcated. So we've got the external iliac artery. We're probably going to have we can't even see the internal iliac artery. It's a bit piddly at this point in time. Here we've got internal iliac artery and external iliac artery. Can you see the external iliac artery is sitting more anterior relative to the internal, because the internal is going to stay internal in the pelvis. This external one, as we go down, is going to come and sit, it's going to come and need to sit more close to that anterior groin crease. So as we go down in slices, you're going to see the external iliac artery come more and more anteriorly. So there it is, there it is. And by the time we get down to the groin, it's sitting more anteriorly. Can you appreciate that? That we went from superior to inferior, but that external iliac artery went inferiorly, but came more anteriorly and superficially. I'll go back. There it is there. There it is there. Going back up, coming back up. Then it was common iliac, and then it came back up to the aorta. It's a little bit to get your head around, but I've got these in the notes so you can sit there and go back and digest and go through them step by step to think in your head, as I'm moving superiorly, what's happening to these vessels and when they're branching and where they're going. Any questions about that? You can sort of see that I mean, these make it bigger, but sometimes it's easier when you get the whole picture and you don't have all of these crazy labels on the images. They can be a little bit distracting. I've got some here. So these, I've got them without the labels so we can follow it, and let's see how we go. What do you think? I'm down inferior to the common iliac vessels. The common iliac vessels have divided. So we're down at inferior to the common iliac vessels. That's all I'll say at this stage. Who wants to have a go at saying what vessel this one might be here?
The
Is that the
external
left
right
area?
external.
It's left. And does
Left
it look,
exterior iliac artery?
so it's going external?
Left external iliac.
Left vessel has 4 components named that when you eventually get the answer, you'd need those 4 components to get it right. If that's the external, if that's the left external iliac artery, it's an artery, and it's round, see how it's round? What do you think this ovally looking thing sitting sort of a bit posterior to it might be?
That'll be the left vein,
The left external iliac vein.
external iliac vein.
Yeah, and this one's sort of round and it's the same brightness as this. So this is more of an arterial phase. Can you see that? So if this was the left external iliac artery, this was the left external iliac vein, and then we've got 2. What one would this one be?
Left internal iliac artery.
Yes, left internal iliac artery. That's right. And then that's the left internal iliac vein. And so you can see the right external iliac artery and the right internal iliac artery there. So as we follow this, let's just follow this one. There, it's coming down there, 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 and there. So can you see that it sort of, as we went down and more inferiorly, it was becoming more superficial. And here it is again. We're just following it again and again and again and again. And then it's bifurcating there. So this is the common femoral, and then it bifurcates into femoral artery and profunda femoral artery. And we're sort of at the pubic bone, so we're at the level of the groin crease here. If this is the left.
Michelle, sorry to interrupt. I feel like you're on the right side.
No, this is definitely the left side.
Is it?
Yeah.
Are MRIs taken from like the feet? Is that how we're supposed to be thinking of it? That we're looking at the feet?
Think of it like,
oh, you're looking down.
If there's a person here standing, like if I had a picture of someone here and we were looking at a photo of someone, and this was going to be their left side and this would be their right side.
They're facing us.
Yeah, they're facing you. Think of them that they're always facing you.
They're always facing us. I thought the back,
No.
the bottom of the, okay.
Yeah.
Thanks.
So always think, you know how I know, and that's what I said the other day, is you're going to get it, and then the next minute you're not going to get it,
Yeah,
and then
that's
you're going to
what
get it
happened.
again. And then it totally happens. So think of it that
So they're going to change, but if they're in a prone position, though, that's the only
yes, they're
time
going to
your left and right will be.
prone. That's right.
Yes.
So just think of that. If
So they're in
you are standing and they are lying on a bed on their back next to you, and you're looking down at them, and their right arm is next to your right hip sort of level. Like you're looking, it's like you're looking at a person facing back at you, basically.
Yep, I've got it.
Just think of it that
Thank
way.
you. Yep,
Yeah.
got it.
But good to
Sorry,
ask.
now I'm confused.
So this is the right side of the patient.
Yes, yeah.
And this is the
Perfect.
left side of the patient.
Thank you.
Always on every axial medical imaging. Like, and when we looked at that pelvis, what we looked at where I'd drawn the piriformis. So this is going to be the right side of the patient and the left side of the patient. This is the right side of the patient and this is the left side of the patient. See how it's the patient is looking at us? So right side of the patient, right side of the patient, left side of the patient, left side of the patient. Is that
So
making sense?
basically it's always the opposite of what you're looking at.
Think of it like looking in a mirror.
Yes, it's like not
Yeah,
looking in a mirror, because that's confusing. Because,
Sorry, I've confused everyone now. Sorry.
I think
no, because when you
other
look in a
thing
mirror,
would be
this is
just-
going to be your left side. It's when it's like
Kind of
looking at
opposite
someone-
sides. Like if
What's
you're
that?
looking
Yes.
at them, your right is their left.
Yeah,
Yes.
Yeah, that's what I was
This is
thinking.
always their right, because this is their right and this is their left. And you have to develop that, because when you start scanning your patients, they're going to be lying down in this position, and you're going to look at them exactly as you're looking at this person's tummy, and you're going to say, I need to scan their right rectus abdominis muscle. I need to put the probe here. I need to go and look at their spleen. It's over on their left side. I need to move my probe over here.
Yeah, I think
It's the opposite for giving. I'm terrible at giving driving instructions.
Yeah,
because you've got to say you've got to go to the right, and like, you know, if you're driving, your right's this direction, but that's the patient's left. Like, it's counterintuitive, but you have to train your brain to think like that.
Yeah.
The earlier you do, the better it's going to help you once you start holding a probe and you start scanning. But you need to do it in terms of looking at medical images, because this is a universal thing. And so that's why we're spending quite a bit of time on it in this first week to help you get your head around it.
Yeah, the other trick I use is, like, you know, especially when I see the axial image or transverse sections, I assume like the patient lying on the bed, and I just, you know, face them from their feet, and I see from down here.
Yeah, and if you're looking from their feet, yeah, you're sort of thinking, well, this is their right side and this is their left side.
That's what I was thinking before.
Yeah.
For the plain images like X-ray or anything, just, you know, plain, right? And just, you know, it's the opposite of just, you know, ourselves, like it's a mirror image.
Yeah, it's just sort of hard, because when you said, is it like looking up? This is not looking up or down. This is just a slice.
Yeah.
and
it's from down. It's a slice from down.
It's training your brain to think like that. It's a different way of thinking. But yeah, you will have it this week, and then by next week you'll be going again. Michelle, just point out the right and the left, and that's perfectly fine. It happens. It's just going through and just developing that thought process again, and it's very good to clarify it. So yeah, this is definitely the right, and this is definitely the left.
Thank you. I had it, and then, like you said, I lost it, but you've got it. So thank you.
No, all good. Always clarify, always ask, because as you asked, there was, you know, 30 other people just going, what? I'm lost. Yeah, so this is the right external iliac artery and the left external iliac artery. It's probably this one, the right internal iliac artery, and it's hard to tell. Like, you won't get questions where it's ambiguous. You'll get questions about where it's clear. So we can definitely tell this is the artery and the vein. See, the artery is more rounded. It's actually more laterally located at this point, because as we get to the groin crease, you're going to see that navy orientation of these vessels. I'll let you, so you've got these to go through as well, and just sit there and go through them and refer to the images in the text as well. But following the series of images will help you think from superior to inferior in these as well. Just watching the time. The diagrams in the notes have it the opposite way. Which notes have the right and the left oriented the wrong way? I wonder. Maybe if someone lets me know so we can adjust them, because they might be wrong if that's not right and left. There are some errors in the textbook, so we do need to be careful of those. But you can see in the text, this has got right and left here. So just when they say there's contrast enhanced CT images, you know what that means. Right. Contrast enhanced image. And I've got some pictures where they're labelled here. Are they helpful from the text?
With textbook readings, what chapters and things like that are we supposed to be reading? Because I can't find it in Moodle.
Oh, it would be in the learning guide. The textbook, it's fairly easy. It's just, if we're doing pelvis, it's on the pelvis chapter in the sectional anatomy text.
Oh, okay, cool.
Don't overthink it. It's just keep it simple.
So I think it's chapter 8. for the pelvis.
Yes, it would be, because this is figure 8.4. It depends what version of the text you have. Sometimes they've jigged it around a little bit and people have different versions. You can use the older versions. Some of the newer versions are supposed to have some of the errors fixed up. I think there's just so many labels in these things, but you do start to go a bit mad. I give presentations a lot, and no matter how much you know, when you're saying very similar words but quite different, you can start to get things confused. So if I ever say the wrong thing, just correct me. When you speak for 2 hours, it's highly likely that there could be an error in there somewhere. Okay. I think we've covered this. The external iliac arteries will give rise to the femoral arteries, and it's basically from groin, around the groin crease is where you've got the common femoral artery, and then it's called femoral artery because it's at the level of your femur, which is in your thigh. And so your femoral artery in your thigh runs all the way down until just above your knee, where it goes posteriorly. This is a 3D angiogram. Angiograms are vessels that show angio is artery, and then you can have venograms which show veins. So a lot of medical talk is based on Latin that has these Latin roots, and so you've got to sort of read into the words to work out what we're talking about. So let's have a look. This isn't contrast enhanced. This is a T1 weighted MR. So this is where you can't just rely on the contrast enhancement to help you pick out what the vessels are, but let's use the Navy acronym and see if that works. We've got the femoral nerve, which is that piddly little thing there. The A should be the femoral artery. That's right. This should be the left femoral artery in particular. And the V should be the left femoral vein because we're on the left side. And then the lymphatics. The lymphatics sit in there, but see, you can't see them on this image because they're so small. So we used our NAV for Y for Y fronts acronym from lateral to medial on the left. Let's check it on the right. Femoral nerve, right femoral artery, right femoral vein, and Y fronts navy from lateral to medial. Can you see how the acronym works? But it's a lateral to medial thing. When you have it from both sides there.
Michelle, are you pointing to the little dot, the nerve? Is that
this thing? You know, I said it was like a really piddly croissant.
Yeah,
it's
right.
That.
Okay.
It's like really flat. So some diagrams make it look. I've tried to make it look more flat there. Sort of like a, you know, when you can get licorice and it's just those flat straps with like the little tubey bits in it. It's like that. It's really flat, that nerve. It's not as round as the vessels. It's a bit smaller. And it sounds like a big nerve, the femoral nerve, but it's actually quite a small nerve. And then it's only about that long. And then it breaks off into a whole lot of other piddly little nerves that run down into the thigh as well. So yes, it's an important nerve, but it's not as big. Your sciatic nerve is a lot bigger and chunkier. And hopefully we'll have time to get through to that. I'll get through. You can just see the arteries are lateral to the veins in this area here. That's just from Complete Anatomy, I think. This is just showing where your inguinal ligaments sit and where your groin crease sits. So you can see when you see that inguinal ligament drawn in the diagrams, don't think that that is this groin crease. That sits up here and your groin crease will sit down at this a bit lower level. Do you think you're going to be okay at unpacking those iliac vessels and where they sit?
With a little bit more practice, yes.
Yeah. And
I'd have
remember,
to look at the textbook a couple more times.
Yes. Remember that we will go through these again when we hit the lower limb. So if you're not quite getting it now, you will need to understand it for your week 9 quiz because we've covered it, but you will develop more understanding of it as we cover things again in week 7 and then again in week 9. We've got a little bit of time left to get over nerves, so I might try and go through those. We did sort of cover the sciatic nerve the other day. We'll go over that. We mentioned the obturator nerve, and we've talked about the femoral nerve quite a bit today. And then we'll talk about the pudendal nerve, the pudendal or pudendal. I call it the pudendal nerve, and you'll see why in a few minutes. We looked at the sacrum and we went, oh, we have these sacral foramina. Foramina are small holes that allow pathways of some of these sacral nerves, which they come and combine with some of these lumbar nerves to make the large sciatic nerve. And often when you see nerves and we talk about nerves, you'll see the sciatic nerve is derived from L4 to S3, and it's just the levels of which these nerves emanate from the spine to come and form this bigger nerve. And so when you see these symbols, this makes more sense again once we've covered the spine. When we have nerves, we have both motor nerves and sensory nerves. What do motor nerves do?
Movement of limbs and stuff like that, fingers.
Yeah, so they actually innervate muscles because muscles help things move. And then we have sensory nerves. And what do sensory nerves?
Touch, pain, senses.
The sensory nerves will go very superficial to our skin level. And if something goes wrong with them, we will get some pain or numbness or tingling as a symptom of when there's an injury or something wrong with those sensory components of the nerves. If there's something wrong with the motor component of the nerves, it can't innervate the muscles, it can't make the muscles move, and then the muscles sort of don't get moved, and then they atrophy and they become really quite small. So you'll see that I often talk about motor nerves. Think of them more going to your muscles or going to things that are doing things, and then your sensory where you will feel some issues or feel nothing if there's something.
Are the motor nerves the ones that get affected during a stroke? And that's why the face droops and one side can't mobilize? Is that where that comes from?
Yeah, it depends the level of the stroke. It's more that the stroke actually affects the brain and the transmission pathway of nerve signals.
Okay, thank you.
Yeah. The pudendal nerve and what we're going to call the pudendal nerve. Why are we going to call it the pudendal nerve?
Because S2, 3, 4 keeps the poo off the floor.
Yep.
Now we should all do that at once.
So S2, 3, and 4 make up this pudendal or pudendal nerve. Can you see it comes from S2, it comes from S3, and it comes from S4. And it makes this pudendal nerve, and then it goes and innervates the pelvic floor. So if our pelvic floor muscles, it's got motor nerves, if our pelvic floor muscles, what were our pelvic floor muscles?
Levator ani.
Levator ani muscles and the coccygeus, but yeah, mainly the levator ani muscles. If they don't work, remember they had that puborectalis sling. If that became really lax and it didn't tighten up when it was supposed to, there's going to be no sling holding the poo back up in the whole pelvic basin, and poo could just drop out, land on the floor, not good for anyone. And that means that, to make that levator ani muscles work properly, we need to get nerve signals going through this pudendal or pudendal nerve. So the sciatic nerve, it's the one that goes out the back. Remember we looked at it and we said, oh, it runs under which muscle did it emerge from anterior to posterior? Which muscle did it emerge posteriorly inferior to? And we talked about that.
The obturator internus muscle.
It's going to sit posterior to the obturator internus muscle.
The piriformis?
Yeah, it's going to sit anterior to the piriformis, and then emerge at the inferior margin of the piriformis to emerge to go posteriorly to the thigh. So yep, that's it. So here it is coming here. Here's our piriformis muscle. So at this point, it sits anterior to it. It emerges at that inferior border of the piriformis, and then it's going to sit posterior to our superior gemelli, our obturator internus, inferior gemelli, and quadrator femoris muscles, which we'll cover later. But it's emerging and it's going down the posterior aspect of our thigh. So if you're sitting down, like the sciatic nerve is more along the part of the thigh that you're sitting on. What's this posterior bit of bone here that I'm pointing to?
Ischium.
Ischium. In particular, it's a bit lumpy. This is our ischial tuberosity. I know it's the ischial tuberosity because there's these muscles, these big posterior thigh muscles called our hamstrings that attach to it. How would you describe the location of the sciatic nerve relative to the ischial tuberosity?
Posterior?
No. If it was posterior, it would be over the top of it.
Sitting laterally?
Is it lateral?
Yeah, so everyone said lateral. Yes, because this is the midline and it's sitting lateral. It's sort of between, it's lateral, it's immediately lateral to this ischial tuberosity. It's certainly medial to this greater trochanter here, but it's lateral to this. That's really important when we start looking at our MR images. So here we've got ilium and we've got piriformis. So at this point, we're thinking our sciatic nerve sort of sits a bit more anterior to our piriformis muscle. Can everyone see that? As we come down, we need to go through the piriformis muscle and go inferior to that. And as we move inferior to it, it can get a bit hard to see. And I've pointed it out here. Can you see how these ischial tuberosities are quite big landmarks? They're easy to see. Can you see your ischial tuberosity here and here? That's our pubic bone. That's our ischial tuberosity. We've got a bit of our obturator internus muscle coming through here. This dotty thing here and here is our sciatic nerve. Can you see that it's sitting lateral to the ischial tuberosity on this image? Can everyone see that?
Yeah.
So often think of where structures sit relative to something big and easy to identify rather than something trivial. And bones are usually big, good landmarks. And so often referring to where nerves or other structures sit to a really big landmark is a good idea. They also,
see, to me, that still looks posterior.
So
because it's behind the bone.
Posterior relative to this, you would think it was sitting here.
So wouldn't laterally mean that it's sitting to the left of it, up higher, even?
Posterolateral, a little bit posterolateral.
Let's look back at this image. It travels from medial to lateral. So superiorly, it's going to sit medial to the ischial tuberosity. But at the level of the ischial tuberosity, when you say where is it sitting relative to the tuberosity, you need to think, well, what's going to be the best descriptive term? Because it can sit, if you said superior, it can sit superior and it can sit inferior to the ischial tuberosity. That doesn't guide where, if you're using this as a landmark, where it's sitting. So when I'm saying where does it sit relative to this ischial tuberosity, superior, yes, but it also sits inferior. So that's not going to be a helpful term to use.
But isn't it behind the ischium? It actually wraps it around it, so it is behind it, which is posteriorly to it.
No, it doesn't go posterior. Posterior to it means it would run down here. See, this is immediately posterior to it. Would be here. In your hamstring. Yeah.
Sorry, would you be able to use the term posterolateral to refer to the to what we saw on the image, not to the whole nerve itself, but on that specific image that we were looking at?
Yeah, if you use posterolateral, I mean, it's posterior usually means like here's this posterior. You would think would be somewhere out here, or immediately posterior. Posterolateral, you would probably think was sitting more out this direction. It's hard because when we do an ultrasound, we're going to scan from this direction here and put the sound in this way. And so posterior, you would think, well, it's going to sit here relative to this, because we're going to be looking from this direction.
So it's kind of like a case of it being like west, south or something like that. So it's closer to lateral. So we'll just refer to
the
it
reason
as
that you're
lateral.
going to say lateral is because there's this chunky thing here, which is also your hamstring origin, which is your hamstring tendon. And that attaches onto your ischial tuberosity as well. And this sciatic nerve actually sits lateral to this hamstring origin, which sort of sits nearly lateral to this ischial tuberosity, attaches onto it. The reason we would use that terminology is when someone does a hamstring injury, they can avulse a bit of the tendon, can pull a bit of this bone off, and they can get really big, thick tears here. And so if this thing went to 3 times the size, it would swell out like this, okay? And when it swells out like this, it's going to squish on this. And so someone's going to get a hamstring injury, and they're also going to get sciatic nerve pain, because it's going to irritate and squish the sciatic nerve, because the sciatic nerve sits immediately lateral to the hamstring at this point in time.
So instead of in the image on the left, where the sciatic nerve appears to be somewhat posterior.
Posterior lateral, like, yeah, it would be right.
So because but as opposed to referring it to posterior lateral, you'd refer to it as lateral because it's known to be sitting lateral to a thing that sits lateral to that bone.
Yes. And so at this level, can you see it's not posterior lateral at this level? It's in the same plane, because the posterior component will change as well, but it consistently stays lateral to it. So that's the most correct term. And don't worry, you're not supposed to have this by week 1 or even by week 4, some of these relative terms. You will develop it as we go through, but it's using the most correct terminology so that you can most correctly identify where a structure sits. If someone says, like surgically, you're going to see, you would say you find the ischial tuberosity, you feel for the hamstring, and then you go immediately lateral to that, and that's where your sciatic nerve is going to sit. Like, that's how we would describe it to someone. If we were going to do an injection around it for some reason, or an injection into the hamstring, we would say, well, you don't want to have your needle going too lateral because you're going to hit the sciatic nerve. You need to make sure your needle comes more medial. And they're the terms that we're going to use because they have clinical relevance. Obviously, you don't understand that yet, but this is where I'm trying to guide you so you know why you need to use them correctly at this stage.
So if you were looking at slices going more anterior, would it become more lateral then as it comes down and around?
More superior. Let me get some and let's go through it. I wonder if I put some in.
Because is that what you're trying to say? As we get to know where everything starts from and then ends up, we'll get to know it a lot better.
It's not easy to see on a CT because the CT, I don't know if I've got the series of MRs in here. They might have been from last week. I will get the series of MRs up in a few minutes. Can I come back to this one just so that we get through these, and I will show you the series of MRs and bring them up, and we will follow the sciatic nerve. I also think these pictures here are, as I said, difficult for you to work out your medials and laterals because they don't show you the whole image. And then once you start seeing the outside part of the body and the medial side of the body, some of those relationships become a little bit easier for you to appreciate because you're seeing a bigger picture. These are quite tight. And moving through a series of images, let's just see. Sorry, I hate flicking through these when everyone's watching. I don't know if I put no, I didn't. Okay, I'll finish this tutorial and we'll go through some of these. I should have put a series of images in, I think, because we looked at it on the other day, thought it might be okay. How about I'll do these extra nerves and then we'll come back to this. We touched on the obturator nerve. We talked about this being the obturator foramen, and that there's a tiny little canal because there's this obturator membrane and the obturator internus muscle that sits more in the anterior aspect of this obturator foramen that allows the passageway of the neurovascular bundle, which is going to be our obturator vein, artery, and nerve. Remember, we talked about it and we said this is our obturator internus muscle, and we recognize this view. We can see the pubis, we can see the acetabulum, we can see the rounded femoral heads, and then there's a little sort of like traffic light sign that sits just in here at the anterior lateral aspect of the obturator internus muscle, and that's where our obturator neurovascular bundle will sit. Usually I think the nerve is the most posterior thing, but sometimes those nerves, those neurovascular bundles can change. Nerves and veins tend to be quite variable in their position. So the obturator nerve, as I showed you with your pudendal nerve and your sciatic nerve, it can arise from different spinous levels. So it's like L2, 3, 4. It comes down and you can sort of see, these are supposed to be muscles. So I've shown that it's got some motor component where it's going to muscles and it's going to activate those muscles. And it does that with some of our big thigh muscles and our pectineus muscle, which is an important muscle as well. So it's going to come down from our spine, come through this little anterior aspect of the obturator canal. That's the whole obturator foramen there. That's our obturator internus muscle. And then it's going to send these divide down and give up off different nerves and branch. And so you can see it coming down here from these L2, 3, 4 sort of nerves, travels down here, travels along the pelvic brim and down through this little canal. Can everyone see that? Where would you describe the position of the obturator nerve relative to the sciatic nerve? Here you can see the sciatic nerve. And here you're going to have your obturator nerve.
Anterior?
Yeah, anterior. It's very much more anterior. Our sciatic nerve is going to run posteriorly. Our obturator nerve is going to run anteriorly. Some people have lateral. I probably would say the sciatic nerve would be more lateral than the obturator nerve because this is lateral and this is medial on this view. It's hard to tell from these diagrams. Sometimes those diagrams I find are really weird. So here you can see your obturator neurovascular bundle here and your obturator internus, and you're going to have your sciatic nerve sitting sort of all back out this direction out here. Let's have a look on this. So our little obturator neurovascular bundles are going to sit in here, and then what it does is this is the pubic bone, then it comes and it sits under this little muscle here called our pectineus muscle. See this one? Our pectineus muscle always sits deep to our femoral vein. So this is our femoral vein and this is our pectineus muscle. This is going to be our pectineus muscle and our pectineus muscle. Can you see a tiny little dot in here? This is our pectineus muscle. Can you see that dot that I have my arrowhead on right there? That's where the obturator nerve comes out through. And we can see those sonographically. I mean, you can see some of those nerves become really, really, really small, and they are really small. And that's where you have to actually know your relative anatomy if you're going to follow those. Would you be able to pick at them on this? Not that you have to pick out what is the nerve and the artery and the vein, but you could pick out your obturator neurovascular bundle and your obturator internus muscle. Everyone feels like they're capable of doing that? Yep.
Yeah.
No, but I will.
I think my head's getting a little bit too much information.
Yeah. We're just keeping it simple. It's coming to the front. The reason it's important is sometimes you can have things called hernias. A hernia is where a structure moves through a little space that it's not supposed to move through. So sometimes when people get old, they lose a lot of weight, and fat was sitting in planes and it held things up in the pelvis, and they lose weight and the fat goes. And just as our levator ani muscles held everything up in the pelvis, sometimes we can get some laxity between some of these other muscles, and bowel can herniate down. Like see how this is bowel and it's coming down and the bowel's poking down into the thigh. Your bowel should not be anywhere near your thigh. It should stay up in your pelvis. When it herniates through a little hole or moves through a little hole where it shouldn't, we call that a hernia. When it does that, so pooge needs to come down here, come through this bit of bowel and come back here. When it moves through this little passageway, it gets squished off, and that means you can't send the poo out and do a poo properly. So you get what we call a bowel obstruction. And so sometimes these hernias can cause all sorts of problems. So this was that pectineus muscle and another muscle, and we're seeing bowel going down into the thigh level where we shouldn't see it. And you asked why we don't look at ultrasound images. These are some images that we get, and you can see that you get no relative anatomy when we look at these. This is showing a muscle in long axis. I've got the probe angled along on a weird like A-shaped angle along this muscle. So this is towards the patient's head and this is towards the patient's feet. This looks like that's their common femoral vein in long axis there and a bit of their artery in here. This is the same sort of image, and this is a bit of their pubic bone, and I'm angling down into their legs. So this is more towards their pelvis, their pubic bone, and this is going down more towards the lower leg, like the feet direction. So this is towards the head and this is towards the feet, and this is the skin and this is deep. And this is a long axis image. So you can see it's very abstract and you would get totally confused, which is why we're sticking to the MRs and the CTs. This is a short axis or a transverse view, and so this would be lateral and this would be medial, and we're going to have the femoral nerve sitting out here. We've got a NAVY acronym, so nerve, artery, vein, Y front in that area. We've got a bit of the femoral head of the hip joint at that point in time. And so when we're looking for a hernia, this is really abstract, and this is why we're not looking. This is on a patient that I scanned probably last year. When there's a hernia, this is their pubic bone. Some of their bowel will come from their pelvis, and when they strain or they like breathe in and tighten their tummy muscles, you're going to see this tissue move up here and come out. This is bowel, which should be sitting way up in their pelvis towards their head. So way up, this is towards their head and towards their feet. So the bowel should be sitting way up in their pelvic basin up here and not coming down and coming down into their thigh. Hence we're sticking to the MRs and the CTs. You're not at all expected to be able to understand these sonographic images at this stage, and that is totally why we're sticking with the more overall images that we're looking at. Another nerve that's coming around the back and emanating along, what was this big nerve that's coming out posteriorly here, going down the back of the thigh?
Sciatic?
Yep, so coming out the back near the sciatic nerve, but sitting, where would you say this pudendal nerve is sitting relative to your sciatic nerve when we look at this image here?
Medial.
Medial. So the sciatic nerve is going to sit lateral to our ischial tuberosity. So where is our pudendal nerve sitting relative to our ischium bone?
Also medial.
Medial, yeah. And so what it does is it emanates from S2, 3, and 4 because that keeps the poo off the floor. It runs out towards the buttocks region and then it comes back because it's going to innervate all of these levator ani muscles. So it comes out the back sort of and then around our buttock, but then it's going to do a loop and come forward again to innervate those levator ani muscles. And so here's our ischium. Here's like the level of the acetabulum. Here's our obturator internus muscle, our obturator neurovascular bundle, our ischial spine, and sort of just immediately posterior to the ischial spine, you can see a little dot, and that's going to be our pudendal nerve. It's really small. I mean, if you don't know those landmarks, you never know to look at them. So you've sort of got your ischial spine right up here, and this is going to be your sacrospinous ligament, and you can sort of see it's just running immediately posterior to that. And so that's where we've talked about the relationships of structures and those ligaments and those muscles, and that we use those bones, and those muscles and those ligaments as anatomic landmarks to help us find some of the really, really, really small but really important structures. Because, you know, on some MRs, you just don't, it's too small for us to see, but we know the region that we're looking in. And sometimes that's the same with ultrasound. You know, some patients can be so hard, but we know we've assessed the right region because we know we've used our relative landmarks to see things properly. So you just can see sort of little dots in here. You can see that if there's problems with the obturator internus muscle, if it was to get some sort of a tear, or if there was problems or tears with the sacrospinous ligament or the coccygeus or the iliococcygeus muscles, that could swell, and that could cause an issue with that pudendal nerve as well. So often when there's tears or injuries to some of our muscles and our ligaments and our tendons, they tend to get bigger, and then they can squish on other structures, particularly small structures like nerves. So I'll let you have a look at those. I won't go through this. I will end it here because I know I'm cognizant of the time and I don't want to take up too much of your time. If anyone wants to leave, you can. I'm going to bring up the tutorial slides which had the MR sequence on them, and we're just going to look at the sciatic nerve and where it sits and follow it from superior to inferior, just so people can appreciate where that sits and where things sit. So just before I finish, the past sessions for this week's stuff will start in week 2. So in week 2, you'll be able to go over week 1 content. Just wanted to remind everyone of that. While I'm getting these extra images up, does anyone want to ask any questions? I know it's a lot of information.
Sorry, I have to unmute myself. I just wanted to check with the content.
Mm-hmm.
So what we're going through in the tutorials is obviously the lectures are far more in depth. So
yep.
Are they more just of like a getting to know before we come into the tutorials?
Yeah, it's putting things in context. So watch them. Like I said, don't take copious amount of notes. Hear the terms and think, oh, okay. And then go, I'll watch these. I'll hear about these structures. And then Michelle's going to unpack it and talk about the most important ones and talk about, you know, I'm not going to, in these sessions, go over the origin and insertion of every muscle and things like that because it will waste too much time. It's more about getting you to develop a way of thinking. In this unit, it's about knowing where structures sit, but knowing where they sit relative to one another and being able to pick them on medical images. Before I talk about that, I do need to tell you where the origins and insertions of things are and what they are, but some of that information is not what you're going to be assessed on, because you could do a whole degree just on the amount of information we have to cover.
Yeah, okay, thank you. Yeah, it was just because it's a bit overwhelming. I think there's a lot of content. And,
yes, so that is, you can, it's because the sectional anatomy textbook really briefly does it, and everyone likes to learn differently, and some people can't pick things out unless they've had certain details explained. And there's so many students that do this. So you've just got to give the information. So passively watch those lectures. If there's something you really didn't understand, then come to these. And then if there's something you didn't understand, go back and look at the notes and pick certain areas of the lectures to help you. Does that make sense?
Okay, great. Yeah, it does. Thank you very much.
Yeah.
Hi, I have another question.
Mm-hmm.
For the arteries, do we just need to know the external and internal iliac arteries in the veins?
Yeah.
Do we need to know the small ones?
Not as many of the small ones. We will go over some, and we will go over some when we do the viscera, because some of them provide blood to certain viscera and some block off after you're born. And so some of them we do understand, but without covering the viscera, like the organs. A viscera is an organ. So without covering the uterus and the rectum and some of those things, you're just going to get lost. It's like a chicken and an egg. Which part do we explain first? So we will cover some of the smaller ones in the part 2, but not all of them, no. So you'll be guided by what we cover.
Okay, thank you.
No worries. In the lecture, I mentioned that the inferior epigastric and deep circumflex iliac artery arteries that are imaged on ultrasound. Oh, well, we can image all sorts of arteries on ultrasound. It depends at what level you're scanning at. So you could be a basic vascular sonographer or a general sonographer or a high-end vascular sonographer. So all vessels can be imaged more routinely. The inferior epigastric arteries, we look at to help us diagnose inguinal hernias. So I was talking about hernias today. They're what we call a vascular landmark. So as I've talked about that, we use some structures to use as landmarks to see other things. We definitely do that for the inferior epigastric arteries. When women have breast cancer and they may have a mastectomy, take a boob off, and they may sometimes have a reconstruction, they often can sometimes take fat from their abdominal wall and use that to reconstruct the breast. So sometimes we have to map all of the vessels through some of that fat to work out, is the fat going to be viable to use in the surgery? And certainly we map the inferior epigastric vessels for that. Deep circumflex iliac artery gets a bit harder to see unless you're specifically looking for musculoskeletal structures. So no, we're not going to look at that very commonly. Hernias can be misdiagnosed as lipomas. Yeah, hernias are not easy to scan. Once again, it's getting to know your anatomy and how well your sonographer is versed in certain aspects of sonography. Courtney says, is that the tram for the abdominal thing? Yes, that's called the tram flap procedure. Transrectal abdominal myoplasty, I think, is what TRAM stands for. You're pushing my memory here. I've certainly done a lot of them in the past, haven't done as many of those scans recently, but certainly did a lot, probably about 15, 20 years ago. Riley says, looking at the labelling of the PDF of like 25 pelvic arteries. So those arteries, like I said, some of them we're going to cover. We're going to cover the uterine artery because we actually scan that in obstetric patients. The umbilical arteries, we look at, it's a fetal remnant, but we not only look at fully formed humans, we also scan fetuses, and some of the fetal blood supply is different to once we're born. So once we're born, some blood vessels can close off because we don't need them. We needed them as a fetus and not as an adult. So I will start to cover that next week when we go over some of those arteries. Some of them, it's just good knowing what their names are. So if it's got a vesico artery, vesico refers to the bladder. So we're going to cover that when we cover the organs of the pelvis. So leave all of those smaller vessels until we cover week 2, definitely. And don't waste your time on doing that this week. Is there a high risk of a hernia strangulating? Yes, depending on the type of hernia. If it's a hernia that completely just pops through and then pops out and doesn't contain, strangulating means it's blocking off the blood supply or blocking off something. So it depends on what structure is herniating and to what degree it's herniating. So often when we're talking about hernia in the groin and that obturator hernia that I showed you, and you get ones around the belly button called umbilical hernias, we need to make sure no bowel is moving through the little defect where it can move through. If the bowel is moving through and it gets stuck, there's more of a chance of it twisting. And once it twists, that's more when we call it strangulating. Do you pop the hernia back in? Some people can pop their hernia back in. Sometimes the hernia is just fat that pops out and it's not another organ, and we're okay sometimes with just fat popping out. You will learn all about hernias. Are a bit of an abstract complex concept. So if anyone's sitting here going, I have no idea what she's talking about with hernias, it took me years to get my head around hernias, I think, so you're not alone. So you're not going to be asked on hernias. This is just information for interest for people, so don't stress. Okay, I'm just going to bring up these. I'm just going to share my screen, and I don't have it in PowerPoint mode, but it's just going to be faster. Let's have a look at this and see if we can see the see if I can put it into slideshow here from current slide. Big one there. Oh, display settings. Here we are. Okay. So let's go through. We're at the level of sort of femurs here. We can see a femoral head and the right femur. And
we
the
can't
right
see your screen.
Oh, can't you? Why is that not? It's hang on. Oh, where did it go? I've hit too many things. Okay, here we are. Okay.
Now we can see it.
Yeah. Sorry, there's like trying to flip between PowerPoints. Okay, let's make our way through iliac bones, iliac bones, iliac bones, iliac bones. Now we're getting to acetabulum and femoral head, femoral head. Acetabulum, is everyone following what I'm saying? And we can sort of see our ischial spines on this.
Yep.
What do you think that dot is there?
The pudendal nerve.
Pudendal nerve, yeah. Like, see, you can pick it out. These are different ones. So see, we're using our pattern recognition to help us see these. So it's not that scary. We just always try and find these ischial spines and point them out. Once we're at this level, so let's have a look. Here's our piriformis here and here. And then we're going to sort of see this bundle of dots here, which is going to be our sort of sciatic nerve region. And you can sometimes lose it a little bit as you go through structures, which is not unusual. Then we know, okay, I lost it, but at this level here, I can't really see it very well, but I know the region in which it should sit. And the reason I know the region in which my sciatic nerve should sit is I know that this is my obturator internus muscle and tendon. What's this thing here?
Oh, the tuberosity. Is it ischial tuberosity?
Ischial tuberosity, perfect. So this is our ischial tuberosity, and this is our region of our pubic bones that is going to be more anteriorly. And then I said, where did the sciatic nerve sit relative to the ischial tuberosity? Where did we say?
Laterally.
Lateral. This thing here is where our sciatic nerve is. It's very small and hard to see, but if I come down, it becomes more obvious here. Can you see that? Can you see at this point, it definitely doesn't sit posterior, and you wouldn't say it sat posterior laterally because that would be out here. When we were looking at the images, that was a case study of one person. So you have to look at a whole lot of different images and say collectively, where does it commonly sit and what's the most consistent position where it's going to sit. So then this is going to be the sciatic nerve coming down here. Can you see that?
Yeah. So as with ultrasound, would we have a set of pictures like this, or would we just be working off what we see and then doing our report off that particular?
Okay, you see the person's bum. You say to the patient, I've got to look at your sciatic nerve, lie on the table for me on your tummy, and then you have to go, there's no protocol for scanning the sciatic nerve. You have to think, okay, I have to find the sciatic nerve, which looks like a whole lot of other tissues on ultrasound, like it's, you know, it's not colourful, like it's the same black and whiteness as everything else there. And so you want to find a really big landmark that's easy to find. Bones are usually that landmark. And that's why I'm saying to you, let's look at where things sit relative to bones. because this is going to be the easiest thing for you to find. And then you go, that's my ischial tuberosity. Okay, then if I scan a little bit more lateral to that, I'm going to find my hamstring origin. And then I've got to go lateral to that because you have to move the probe to find it as well. The patient doesn't come in and say, here's my sciatic nerve. This is where you have to put the probe.
What, they don't have it tattooed there?
No. And that sounds easy when you're looking at it here, but you see their whole back of their pelvis and their whole bum and their leg, and you think, what level do I put that probe at as well? So it makes it look like it's really easy here, but finding a sciatic nerve is not an easy task for a lot of sonographers because, one, they've forgotten where it sits, and two, they don't know any relative anatomy of where it sits, and they become flustered and they start getting the probe and going, oh, oh, and get really flustered and spend half an hour in there and go, I found nothing. It's like, okay.
I think that's going to be me.
So this is where you have to have, and you have to develop this very rational thought that we're developing in this unit. Otherwise, you go down these flustered spirals, and every sonographer goes through them, and everyone will do it. I've done it so many times, and it's only in my experience and my lens of looking back is how I know how you have to think and how you have to systematically develop these thoughts and stay calm. Because there's no textbook in the room with you and the patient.
Not allowed to use Google on your phone?
No. That is not consistent with hand hygiene and infection control.
Oh, bugger.
And you don't have time. Particularly if the patient's on a trolley, you know, like they're hooked up to drips and all sorts of things. There's things beeping, there's people doing all sorts of things in the room. Nothing's nice and easy. So did that help going through that? Like you can see that we can't actually see it.
Yes, thank you.
So there's some images where you just can't see it and it becomes a bit obscure because it's traveling at different pathways, and you're going to lose things on different views, and then you're going to need to pick it up again. And so some structures you're not going to be able to follow the whole way through on these images as well. So if you're going through them and finding that, that's completely normal. Any other questions?
No, but thank you very much for today. That was really great.
That's okay. The easy thing is to get overwhelmed. So try not to get overwhelmed. Just go back through what we've covered in this. And when you break it down, we didn't actually cover a whole lot of stuff, but we a lot of structures, like compared to what's covered in the lectures.
It felt like we did.
Well, look at the first slide because I tried to break it down. I'll go back to the first slide and I'll show you what we covered. And you'll be like, oh, okay, we didn't actually cover that much. So share screen, this one. We covered the muscles of the pelvic floor. We covered the coccygeus and the levator ani muscles. Then we covered pelvic arteries and pelvic veins. And then we covered some nerves. So when you break it down, that sort of gives you a list of what we covered in this study group. Does that help?
That still seems like a lot.
It does, doesn't it? It still seems like a lot.
Less than the lectures, though. Hopefully.
It's like I understand it and I kind of get it and I'm kind of seeing it.
Yeah.
But I still have to just remind myself we're still in week one.
We're week one. Yeah, don't be too hard on yourself. Week one and we step it up. Just keep thinking that.
I think that's what's scaring me. If this is little amount, what the hell's week two going to be like?
Well, week two, we're still on pelvis. So we're going to go back over again and we will be looking at these structures again because these structures will help us find other structures. And other structures will actually help us find these structures as well. It will make this seem a lot easier once we cover some more as well. So it will put things into context. You will go by the end of week two, you'll be like, oh, I didn't even notice all those things on the MR and CT, but now I see those. It actually makes it not as overwhelming because I've got more of a map of what I'm looking at.
Yeah, I guess once we know what all the other blank bits are on there that we're looking at.
You will, yeah. It will all add up, hopefully. Okay.
Well, I'd like to say I'm glad you're teaching us, because I think that I understand a lot more with your teaching skills than some previous ones that I've had. So that's a bonus.
I've made lots of mistakes in things over the years, and I've gone down rabbit holes of trying to work things out. And so I know what it's like to be very lost.
I know in our group chat, after the lecture on Tuesday, everyone was like, that was so much better, made us feel so much better about the unit.
Yeah, it looks a lot and everyone freaks out. And that was my first thing the other day, is don't freak out, because the more you freak out, the less rationally you think. And this is all about starting to think rationally and develop a rational and systematic approach. And it seems like a bit more effort, but if you do develop those thought processes as we go through different areas, you'll think, oh, I'm just still applying the same principles, just to a different area. And it's going to be the same way you need to think of when you put the probe on a patient and you start scanning. And that was my first sort of email, that if you think you're going to get through with rote learning is great for getting you through an exam, but it doesn't help you when you start to have to move the probe and you think, oh, I should have worked out what was superior and inferior, because I have to move my probe superior and inferior. I have to move my probe medially and laterally, and I have to work out what structure is sitting more to the patient's right and patient's left. And so if you've already developed those thought processes, your scanning is going to become a lot more easier.
Yes, there's definitely no cramming in this subject.
No,
that's for sure.
It doesn't usually. Cramming just ends up that you don't think rationally and you go down the fluster spiral. So yeah, just slowly just go over it and look at that list of things that I said that we covered today. Make sure you can find those in the medical images, make sure you can find them in the diagrams, and make sure you can think, well, where did that sit relative to that other thing we talked about? What's the best way of learning when to move the probe? Knowing your anatomical directions, because once you start holding it, we're going to say move the probe superiorly. And you're like, if you haven't worked that out, or move the probe laterally, move the probe medially. So start holding a cursor over your medical images and going medial, lateral, patient's right, patient's left, because the same way you're putting your cursor is the same way you're going to have to move your probe.
Michelle, can I just ask you something off topic completely?
Yeah.
Well, not completely, but I noticed you're presenting at the SIG Day.
Yes.
Do you think that's beneficial for students that are able to attend?
That one's an advanced musculoskeletal. You will probably end up in the fetal position. You can come along, but there's lots of sonographers that end up feeling like they're in the fetal position after coming to those. So that's not even basic musculoskeletal. There'll be a whole lot of structures we haven't talked. It's only next weekend. I've got so many. Nearly every Saturday, I feel like I'm presenting at some conference at the moment. That one, I think the SIG Day, I think they've given me foot and ankle.
Yeah.
So you're very welcome to come along, even just to see what an ultrasound workshop looks like. We are going to have one at the Sydney campus. Are you Sydney?
Yes, yeah.
We're having one. I'm supposed to be speaking at that. And Julie Cahill did give me the name. I feel like all I'm doing is flying around the country speaking and doing ultrasounds everywhere at the moment. I can't even remember what day that is. I could look it up for you if you want me to find my diary.
Oh, no, it's okay. I just saw the SIG Day come up, and
I know. Certainly come and see what an ultrasound conference is, and you'll go, oh, wow, I really am glad that I'm doing this. But just sort of expect to be sitting there thinking, I think I've attended a conference in a complete other language. But if you sit there and just say, I'm just going to see what they're talking about, I'm going to see what sonographers do and why they're doing it, it would be good for that.
Yeah.
But you will probably expect to understand about 2% of it.
Yeah, okay. And then networking as well, that side of things, I guess.
Yeah, I'll be there. You can come and say hello. Yeah.
Okay, great.
And we need a volunteer. I think that, and if anyone volunteers to be scanned, you get a $50 voucher or something like that.
Yeah, I've done a couple of those, so I've just found it really beneficial to attend them, and yeah, even though you're being the person scanning, you still learn.
Sorry, I'm not her voice again. Yeah, there's some good presenters. There's Martine, who does a whole lot of arthritis she's amazing. And then there's Greg Lammers, who's amazing as well. And you'll really like the way we all present a little bit differently, which is good. So it's not all the same.
Yeah.
And it's a lot of it's talking and then scanning. I was going to just mostly scan because that's what a lot of sonographers want us to do. I feel like I bore people immensely with PowerPoints.
Yeah, okay.
But I will have some prepared, but I was going to do the scanning first and then the presentation after.
Okay.
If I had time.
Great, thank you.
No worries. Would that that presentation be on Zoom, Kelly? No, you have to pay money to attend that. The ASA, they've done the ASA conference had some virtual component to it, but the big national conference, but this one's it's not hybrid, it's just live. It's because it's more scanning. They don't usually video the scanning component, which is a real shame because that's what everyone loves. It's called a workshop. But when they say workshops, that's us scanning at an ultrasound machine and showing people how to scan and what we're doing, how we're moving the probe. And it would be me saying, I'm moving the probe more posteriorly, more laterally, and all the terms that I've used in this lecture. Are there on-campus sessions that teach scanning? That's year 2 and 3, and that's a lot of them. So year 2, the year 2s are on campus every day in term 2, scanning the abdomen. It's pretty full on. In term 1, you come on campus and you're scanning a thyroid. You also in term 2 scan pelvises and things like that. We don't do anything in year 1, more because the labs are so full. When you get to second year, you'll see what there's the second and third years consume the sonography labs. They go night and day, and we had students coming on campus. It just got really hard with COVID, with getting everything would shut down. And so when one campus shut down, everything would shut down. So it was easier to embed the learning to being online. And what we found is that the scanning didn't translate to anyone being able to scan when they got to second year anyway. It's you get to hold the probe, but it doesn't actually translate to any more understanding of anything. You actually need to know all of the anatomy before you scan. Yeah. And you will appreciate that. You'll appreciate that it happens in second year. Everyone touches the probe and thinks, oh, I can do this. This is really easy. And then every week you go, oh, it's actually a lot harder than I thought, because you realise the detail that you need to appreciate. But, it's fun. It is good. And it's satisfying. It's hard to teach those skills, and then you lose them again by the time you're back in year 2. Yeah. Any other questions? No?
No, but thank you. It's been great.
No worries. Well, I will let you go, just so I can start the recording process, the rendering process of this, because the longer we hold it, the longer it takes to render.
Thank you, Michelle.
No worries. Just passively watch those lectures for next week as well. Don't take a copious amount of notes. Your notes will come from these tutorials and study sessions.
Thank you.
Okay. See you.
Yeah, if you're from Melbourne, you can get a book at the library.
Oh, can't quite hear there, Henry. What was that? Maybe put it in the chat, because I can't quite discern what you're saying. It's like, I think your signal's cutting in and out. No. if not, if you miss the chat, you can send me an email and I can. Can we find the textbook at the Melbourne campus? Is there an online version? Have you tried the online version of the textbook? There could be one at the campus, but I would certainly just check on your CQ Uni library access to see if you can get it online as well. Yeah, that's much easier. And then you've got the images. You can borrow it for a week or however long, but check online. I certainly have an online version of the text, which is handy. But the version I have doesn't have any of the words or anything. It's only got the images. But certainly if you don't have the words and you just get the images, the information I've given you in the tutorials and the study groups is adequate. So even if it is just a version with the images, that could be helpful.
I think there's something called Z Library, which you can download stuff for free. And I'm pretty sure the sectional anatomy is on there as well. I managed to get one off like Facebook Marketplace for $30. But I think a few other people have used Z Library, and you just sign up and I think you can download 2 textbooks a day.
Okay, Z Library.
It's really good. So it's like, I think I've downloaded the other sectional anatomy, but I haven't really needed it. But I've also downloaded the Gray's Anatomy from it as well.
Just Z, the letter Z?
Yeah.
Okay. I probably won't put that in the chat just in case we've got any copyright issues like in an email, but that's really handy. The reason having one online can be good is when you go out on a placement eventually, and you do have to look up MR images, having that text can be really helpful, because you think, oh yeah, you focus on ultrasound while you're at uni, and then you get out on placement and they start showing you all these MRs that you're supposed to interpret, and you're like, oh, we haven't covered that since first year. And so having it as a online text that you can take with your computer when you went to a placement could be handy. But certainly, I mean, I like the paper text as well. It depends how you like to learn.
Well, I think because I got the 3rd edition or 2nd edition or something like that, 3rd or 2nd, and I wasn't sure if I needed the 4th edition. So I downloaded the 4th edition, but I've got the 3rd edition as a textbook.
I think I've got the 3rd on as the images on those slides anyway. There's not a lot of difference between them. So yeah, the anatomy hasn't really changed. We do find a little bit more with anatomy, but I think it was just more fixing up a few little errors that were in there with some of them.
Yeah, I figured the bodies don't change all that much.
No, we still are finding more information, but it's more detailed. Yeah.
Right.
Okay.
Yeah, thank you for today.
That's okay. Good luck with getting through everything, and I'll see you next week.
Thank you. Bye.
Okay. Bye.